Gangaram Hospital. Dr. Vidhi Singh.
So you need to put the mics.
Also give us mic.
So for the camera.
Go ahead.
Good evening, sir. I am presenting the case of Mr. SS, 53 years old male, residence of Roorkee, graduated, businessman by occupation, history given by patient himself and seems reliable. He was admitted to us as a prospective renal allograft recipient on 10th of July 2024. History of present illness, I would like to date back my history to 2004 when he was 33 years old, having trivial trauma over the left foot, following which upon taking the medication was not relieved. On evaluation for the same, he was told to have increased blood sugar levels and increased blood pressure. Rest of his blood and the urine test were told to be normal. He was started on oral medication for diabetes and hypertension. Upon direct questioning, he had no history of excessive he gave no history of excessive urination, increase in thirst, increase in appetite. He gave no history of burning sensation, paresthesias, numbness over bilateral feet and hand, and no complaint of blurring of vision. Till 10 years, that is till 2014, he was having regular follow-up visits, and according to him, his blood sugar and blood pressures were controlled. In 2014, he started complaining of froth in the urine, which was associated with early morning facial puffiness and pedal edema. It was not associated with shortness of breath, decreased urine output. And for these complaints, he consulted his physician and told to have loss of protein in the urine. And he remembered it to be 2+ to 3+. And his serum creatinine was told to be 1 milligram per deciliter at that time. He didn't remember the exact value of blood pressure at that time. According to him, his medications were modified for both for diabetes and hypertension, and he was told to undergo ophthalmological checkup. And according to him, at that time, ophthalmological examination was normal. He was compliant to treatment, but still his blood pressure and blood sugar levels were not controlled. The patient has persistent proteinuria and pedal edema, and in 2017, he was started on injections insulin. He remembered it was initially injection Lantus and followed by injection Mixtard, and rest of that he was receiving the oral medication. In 2021, patient had complained of ghabrat, chest pain, uneasiness, shortness of breath. For this, he got evaluated outside and was told to have acute coronary syndrome.
When was that?
In 2021, sir.
Okay.
After optimization, patient underwent coronary angiography and stenting was done. After the procedure, he told his serum creatinine was increased and it was 1.7 milligram per deciliter at the time of discharge. And he remembered that his medications include the blood thinners and lipid lowering agents also. After the follow-up of 1 week, his serum creatinine decreased to 1.4 milligram per deciliter. His antihyperglycemic agents were optimized and dose of insulin was adjusted at that time. After that, his serum creatinine fluctuates between 1.4 to 1.8 milligram per deciliter. He took some alternative form of medication to decrease his serum creatinine, but his serum creatinine continues to show the increasing trend. In 2023, his serum creatinine increased to 3 to 3.5 milligram per deciliter and urine protein was 2+ to 3+. He also had complaint of blurring of vision at that time, for which his repeat ophthalmological examination was done and told to had effect of sugars in the eyes, and he was given some intraocular injections in bilateral eyes. He also experienced 2 to 3 episodes of decrease in the blood sugar levels, which were decreased up to 70 milligram per deciliter, after which his insulin was stopped and he remembered taking only a single anti-diabetic agent, and that was Tregenta. He also gave history of numbness over bilateral feet, but gave no history of pain in the legs while walking and blackish discoloration of the toes. His creatinine continues to rise, and by the May 2024, his creatinine increased to 8 milligram per deciliter. At this time, he was counseled regarding the renal replacement therapy, and both the dialysis and the transplantation modalities were discussed with him, and vascular access creation was advised. But he opted for the renal transplant surgery. At that time, he had no history of fever, decreased urine output, burning micturition, poor urinary stream, increased frequency of urination, and no history of blood transfusion till now.
Good, good. Your history presentation is good. I must compliment you. All right. Now let's go to second year. Can second year students raise their hands? You can just brief You can just give us the gist of the summary what she has said.
The 54-year-old male who has presented initially with
Latecomers in the front row. In the front row. Yeah.
it's a history of a 53-year-old male who was incidentally diagnosed to have diabetes and hypertension after the non-healing ulcer on the foot.
First year? Any first year student? Yeah. You can just give us brief basics. How do you diagnose diabetes? Very simple question for you.
Fasting blood sugar, post-fasting blood sugar, and HbA1c.
Tell us.
Fasting blood sugar more than 100 to 126 will be pre-diabetes, more than 126 will be.
So one is 126 plus. Next.
Plus postprandial more than 200 and HbA1c more than 6.5.
More than 200 with symptoms.
With symptoms.
Not without symptoms. Okay, sit down. So patient was found to have diabetes. This was, she said, somewhere around 2004 or so, 20 years back. And at the same time, you said he was detected to have hypertension also. And there was no proteinuria
At that time, they were.
at that point of time. Third year student, will I call it that this patient had diabetic nephropathy at that time? Final year. No, I'm asking you.
Because at that time, urine microalbumin was not checked at that time, and because in the urine there was no protein.
No, she said there was no proteinuria. So patient is not having proteinuria. Does the patient had diabetic nephropathy or no? You can't say. Other final year student? Third year? Only one? You are third year. What is diabetic nephropathy?
So, diabetic nephropathy is a histopathological diagnosis.
If I don't do biopsy, I can't label a person as diabetic nephropathy, you
so
mean?
we can say diabetic kidney disease. We can have deranged
What is the
renal
definition of diabetic nephropathy?
Sir, it is diabetes with albuminuria and deranged renal function with histological diagnosis of mesangial expansion glomerular.
Is it a criteria for saying diabetic nephropathy? The criteria has remained three only. That a person has to have proteinuria. How much?
Proteinuria more than 30 milligram per gram of creatinine and
To call a person diabetic nephropathy, basics, you cannot be wrong in basics. Proteinuria of albuminuria of 300 milligram or proteinuria of 500 milligram a day. That is one. Number two,
EGFR less than 60 ml per minute.
not necessarily. Decreasing GFR.
Decreasing GFR.
Whatever was the original GFR, GFR is coming down. And third, hypertension. The biopsy criteria is not there. Am I right?
Huh?
There is no biopsy criteria.
It's just you are going into the terminology like RPGN is a clinical term, where presenting nephritis is a pathological term. That way, but now RPGN has been taken as a a pathological term also. So don't go into that. What we are asking is that if a diabetes is affecting kidney, that you take it as diabetic nephropathy. So how sir is asking that, how do you define?
So
what are
that
the
is what
defining?
you should know. That the person is having proteinuria, he is having decreasing GFR, and there is a hypertension. So if these three conditions are fulfilled, person has got diabetic nephropathy. Please sit down. So you are saying, because at that point of time, there is no proteinuria. So there is no question of diabetic nephropathy. The basic requirement is proteinuria. And that was not there. And what is diabetic kidney disease? She said, are they different terms or it is the same term?
Diabetic kidney disease is albuminuria more than 30 milligram per gram or EGFR less than 60 ml per 1.3 meter square.
diabetic kidney disease is a broad term where the underlying etiology, cause can be anything. Suppose a person has got atherosclerotic disease also in between. Suppose a person has got more damage due to hypertension. So, diabetic kidney disease is a bigger umbrella, which diabetic nephropathy will also fit in that. So, it will encompass other things also. All right. So, please come. Front row. Latecomers are front row. So, that is one. So, this patient had diabetes, this patient had hypertension, but there was no proteinuria. And gradually, now, whatever she says, after 10 years, 2014, they found, when was the proteinuria first detected, you said?
2014, sir,
After 10 years.
to 10 years.
Is this a normal course of type 2 diabetic nephropathy?
No, sir. So, no, this is not the normal course of type 2 diabetes mellitus because most of the patients in type 2 diabetes have proteinuria at the time of the onset of
Can
diabetes.
be. I mean, not necessarily.
Not
but
most of them.
Not most of
majority
them, yeah.
Little, no, not even more majority. It all depends on the social profile from where patient is coming. You know, some people are more well investigated. Nowadays, investigation are so liberally available. So you are diagnosing more. So you can't say that patient will always present in advanced renal failure.
You can rather say he may present with proteinuria right at the time of diagnosis, but that is not an essential thing. Generally these days, as Professor Bansal is telling you, nowadays many patients are being referred to you by endocrinologists or by physician, and they are being referred when there is only a small amount of proteinuria. So there may be proteinuria, but not significant amount of proteinuria in these people.
One, there is a bias in our practice because we are seeing nephropathy patients who have already developed some investigational problems, they are referred to us. Once you go into general practice and see diabetics, you will see a lot of diabetics who don't have proteinuria or renal dysfunction. So we are not seeing those group of patients. That's why we feel that majority present to us with proteinuria.
Front.
So we all know that what is the natural history of a diabetic nephropathy. So what is the natural history of a diabetic? Let us say there's an index case of person developing diabetes detected now. So what is the natural course in type 1 diabetic or a type 2 diabetic?
So in type 1 diabetes, first of all, there is a stage of hyperfiltration, then followed by the silent stage in which GFR decreases, and there are histological changes, but clinically there is no symptom. In stage 3 silent stage, when there is when albuminuria is moderately increased.
So in a
albuminuria
type
is
1
there.
diabetic, what would be the duration when the patient would land up with a stage of microalbuminuria?
Sir, it is silent stage is from 2 to 5 years, and the incipient stage is 5 to 10 years.
So it might take 10 to 15
10 to
years
15 years. That is what
before
is
a
important.
person will have microalbuminuria. Is microalbuminuria correct term?
No, sir.
What it should be called?
So nowadays it is moderately increased albuminuria.
You say just albuminuria. There is nothing called microalbumin. At some point of time, people started saying very small amount of protein is leaking out. It is microalbumin, but there is nothing called microalbumin. It is a small amount only. So nomenclature remains albuminuria. So this patient, after 10 years, he started having albuminuria and frothiness and puffiness.
Yes, sir.
Why patients with proteinuria have got puffiness? We are asking basic questions. If somebody is having proteinuria, why he develops puffiness or edema?
Albuminuria causes matlab there are two theories about it.
Yeah, very good.
Underfed and overfed theory, which causes retention of water in the body.
Why? Why there is retention of water?
Because of retention.
What is the normal oncotic pressure? Normal oncotic pressure in our body, how much it is? Shabash, 25 millimeter. So that is the 25 millimeter, and that is predominantly by proteins. So if there is hypoproteinemia, If the protein is leaking out, if the protein level becomes low, the oncotic pressure will become low. Oncotic pressure is only holding the water in the blood compartment. So the fluid will start leaking out. So whenever there will be hypoproteinemia, fluid has to leak out. The other theory you said is,
Overfill.
Overfill.
what is that?
Increased activity of neck channels will do more sodium retention.
So there is more sodium retention that is giving rise to. So this patient develops, she says, frothiness in the urine. Frothiness means what? Frothiness is not synonymous with proteinuria, keep in mind. There are many causes of frothiness. Even if a person is having bile salt, there may be concentrated urine, whatever. So don't correlate any patient coming with frothy urine. It may suggest it could be proteinuria also, but it is not synonymous with that. So patient started having frothiness and that. So that means the patient came to which stage?
Stage 3 or stage 4, sir.
Stage 3 or 4? All right, then what happened? You said the insulin, he was taking insulin, the insulin requirement became low.
Sir, initially he was started on insulin in 2017, and
Yeah.
by 2023, when his serum creatinine start rising, so he has episodes of decreased blood sugar levels, following which his insulin requirement was decreased.
Why it became low?
Sir, because in advanced, whenever we have advanced kidney disease, then the insulin, there is decreased clearance of the insulin by the kidneys. So there is a
Clearance means the insulin is filtered easily. Insulin is easily filtered, molecular weight is low. What is the molecular weight of insulin? I think 5,000. So it is easily filtered. So clearance means what?
so it is
Metabolism.
filtered also, metabolism.
Don't say clearance, metabolism. 60% of insulin is being metabolized by the tubules. 40 to 60%. So if the metabolism of the insulin is not there in advanced kidney failure, logically insulin will keep staying in the body. So that is why a large number of patients, by the time they reach end stage kidney failure or advanced kidney failure, the insulin requirement may come down or disappear. So this is what happened to this person.
Yes, sir.
Okay. Now if I do a biopsy in this person, what do I expect?
Sir, we expect the glomerular.
Will you do biopsy in them?
Sir, since he has no other systemic manifestations, there is no other sign or symptom suggestive of any other disease, so he may not require biopsy.
You tell me, you said his creatinine was in 2021, 1.4.
Yes.
When he had angiography, he had stenting, creatinine was 1.4 milligram. I don't know how much is the GFR it turns out, maybe 640 or 45. Now, then you said next year the GFR becomes 50%. It became 3.5,
Yes.
22. Next year it became 8 milligram.
Sir, after 2 years it became.
So what is the drop? Calculate what is the GFR with 1.4 milligram? And what is the GFR with 8 milligram? Just calculate. 8 milligram creatinine. Person is 53 years. Which equation you calculate? CKD? EPI. Yeah, okay. How much is 1.4?
59.
59. So GFR was 59 or 60. This is in 21.
2021, yes, sir.
And now in 24, it is how much? 7. 7 or 8. So the fall from 60 to 8, a drop of 50 in 3 years. That means a yearly drop of 17, 18 ml. Is it expected?
So it is larger than, as in diabetes, we expect it to be 8 to 12 ml per minute
8 to
per
12
1.
is very high. Still 8 to 12 is high.
If the patient is not taking
If a
ACE
person
inhibitors or
has-
SGLT2 inhibitors, then it is 8 to 12. But if the patient is
No, it's how much? You are targeting 3 ml per year. If you are
more than
giving to a
6 is a
person,
rapid decline.
yeah, if you are giving to the person whatever ACE inhibitors and whatever ARBs plus SGLT2 and whatever,
then we target.
you expected, that is your target. That GFR drop should be 3 ml per year. 3, 4, 5. Because more than 3 ml is a rapid progressor for any CKD. So here he has been a very rapid progressor. Will you do a biopsy or not? That's why I asked you.
Yes.
And you said no. When do you do kidney biopsy for them?
So when there is a rapid decline in the
That is one situation. There is so rapid decline. If there is hematuria, if there are RBC cost, if the, whatever, or if there is a rapid decline, what do you think is the cause of rapid decline in him?
So first possibility, it may be because of the contrast associated damage, because he
When
underwent.
he received contrast, at that point of time, his creatinine, you said, was 1.7 milligram.
Yes, sir.
Our GFR was 55. Does contrast cause kidney damage? That is also a point of debate.
Yes, sir.
The Mayo College, I remember 2-3 years back in the American Society, there was a big debate of almost 2 hours. One total session was, does contrast cause any damage? And their consensus was, if the GFR is over 45, we don't bother. Now his GFR was over 45. So why should he develop that much of damage?
Oh, sir, it may be because of the atherosclerotic disease. Because
Extra?
as he underwent the coronary angiography followed by stenting, so maybe cholesterol embolization might have occurred.
But you said after his discharge, his creatinine came back from 1.7 to 1.4.
And after that, he has taken some alternative form
Yes,
of medication also.
that is important. What you are saying, that if he is taking alternative medicine, we don't know what is he taking. They can cause damage. This, I think, Dr. Saab will agree. Many patients he would have seen who come with whatever, Ramdev ki medicine or any medicine, alternative medicine, their damage is pretty fast. I don't know why. This is more of an interstitial damage or what. I recollect 20 years back, we started in army, there was in civil, there was a trial going around for mulati. What you say? Pan mein dalte ho mulati. It is called Glyrisa something. So this was a treatment for hepatitis C those days. So our gastroenterology team, very learned people, so they said we will do a trial with this. So I remember that time we gave to some patients of kidney transplant recipients who were hepatitis C positive. I remember 2 of them, there was a rapid rise in creatinine. We did a kidney biopsy and our pathologist said, I have never seen a biopsy like that. It's all full of inflammation. So we don't know what medicine, what drugs, what alternative drug they give. So that can be bad. So one of the advantage of doing a biopsy in such patient is, if there is any
Reversible
interstitial nephritis or anything, possibly you can treat it. Because here he has gradually deteriorated with a rapid drop in GFR. Mind you, AIMS conducted a study, they gave a dissertation to one of the students, and there also, all patients, we also have been biopsying all patients who are having rapid drop, but unfortunately we have not found any cause. And AIMS also in their dissertation, they found that there is no definite cause. Some people have a rapidly progressive course. For reason we don't know. So it could be one of those causes that there is a rapid deterioration, or it could be an alternative medicine, or something different he has consumed which could have caused this rapid drop. That in a phase
what could
of...
be, in your case, what could be causes of a rapid deterioration. What are the causes of rapid deterioration? That is the question then. One is alternative medicines. Then in a diabetic patient, what else can be there?
Atherosclerosis.
So they can be a vascular disease, है ना? They could renovascular disease overlying a diabetic nephropathy. Then what else? Cystopathy. Diabetic cystopathy can be there causing obstruction. Sometimes patients just come to us, the creatinine is rising. You do ultrasound, you'll find there's 70% post-void residue. Okay. Then there can be repeated infections. Causing chronic pyelonephritis. You should always, when you are assessing renal failure, any sort of jump in creatinine or any renal failure, you should analyze in totality, like pre-renal, renal and post-renal, and try to figure out what could be causes. Any patient, like this patient had a jump of creatinine to 3.5. So that time he should have been evaluated. He must have been, but in history you should say that at that time he did not have any diarrhea, he did not have any vomiting, his BP was okay, there was no fresh change of medicines, ACE inhibitor, ARB or some medicines. You have to find everything. So your history was very incomplete in that sense, that whenever there is a jump in creatinine, you should find history for all the other causes. Should not limit to diabetic causes only. And if you see a more wider spectrum, like in Delhi, the incidence of diabetes in general public is 15%. So if there is so much of diabetes, your diabetic patient will have other renal diseases always.
Yes, sir.
So you have to be have open mind. So there could be other glomerulonephritis, and AIM study, sir said, it has highlighted minimal change disease, IgA nephropathy, membranous nephropathy. 60% of patients had other nephritis. In biopsy diabetic patients who could be biopsied as per the criteria. So definitely should have look out of other diseases.
So don't hesitate on biopsy. You can pick up different things.
I will tell you, one patient came to me. He was a stable CKD patient, diabetic nephropathy. His creatinine used to be 2 and it slowly started elevating till 3 over 6 months. I told him it's part of your nephropathy, maybe your hypertension control is not this and that, and he was not convinced. Then his creatinine further rose after 3 months. Then I was telling him every time to get an ultrasound, and there was one stone in one of the ureters. There was no pain. One ureter was blocked. His creatinine was rising because of that. We removed the stone and it came down. So there are a lot of instances where you will find recoverable causes, and as a nephrologist it is our duty, before we label somebody as a chronic kidney disease or irreversible, progressive, these are the two terms for chronic. So we have to be sure, we should not leave any stone unturned to improve the kidney function. Okay,
right? So I think you can give some idea now to the crowd, before we go to the what happened in the transplant or something, what preventive strategies you recommend for patients with diabetic nephropathy?
So, first of all, we will limit the salt intake. Salt intake, sodium should be less than 2 grams of salt, NaCl should be around 5 to 6 grams per day. So one is that part. So
Now, what is the normal intake?
So normal intake we take around 2 grams, 4 or 5 grams.
No. What is a normal Indian generally taking? How much salt a normal Indian is taking? Yeah, that's all right. 10.98. That is, I think, Dr. George Institute study that 10.98 gram is the average consumption by an Indian, which is more by South Indians because possibly they take sambar and other spices. So it is higher in them. So that is the normal 10.98 or 11 gram, and the recommendation is 5 gram. Okay, that is one. What blood pressure you want to keep for the patient? First is, what is the sugar control you want?
So according to the age, we basically, if the person is around 54 age, we will not try to decrease the HbA1c to 6 or 7, we keep around 7 to 7.5.
Around 7 you said. That's all right. That is a UK PDC.
Try to get less than 7.
Yeah, UK PDC trial that you want to keep it around 7.
So then the latest EU guidelines recommend that with respect to the proteinuria part, you have to limit the BP to less than 130/80.
Maybe less, that certainly the recommendation by the trial is 120 by 80, but if that is not possible, 130 by 80, it should be less than that.
The accord it has now modified to less than
130 by
80.
Lot of people are doing work on that, and there are different values, different things. Basic idea is 140/90 is a very, very hard cutoff, and anything below that which can be tolerated, preferably 130/90 or 130/80 or below, but it should be tolerated. There will be patients who will not tolerate, so you have to be checking that.
So that is number 2. You said blood pressure you have checked. Blood pressure, what antihypertensive you want to give?
First, I would like to give ACE inhibitors only.
There is no proteinuria initially. When the patient came, if there is no proteinuria, GFR is normal, there is no recommendation for
So
ACE
there are no
inhibitor.
recommendation for actually any drug. I still prefer sir ACE inhibitors also.
Why?
So because of cardiovascular, sir,
That is different. If he has developed that, one of them. Otherwise, you can give whatever antihypertensive if the blood pressure is there. But yes, if the GFR is coming low, if the proteinuria is appearing, ACE inhibitors you are giving. Okay? Now, you have controlled blood pressure, you have controlled this.
so diabetic control, blood sugar control.
You have done that. Salt restriction you have done. You have told him to stop smoking.
Exercise.
Moderate exercise you are doing. Now, what protective measures these days you are recommending? One is, you said ACE or ARBs. What is the protection offered by them? How much slowing of progression of kidney disease they will do?
On ACE inhibitors, if we have properly controlled the BP and everything, so the GFR should not be more than 5 ml per minute in 1 year.
No, that is different. Overall protection offered is around 20%. Slowing the. So that, because all the trials, whichever, can you name, anybody can name any trial? You can name the trials. Diabetes trials, ACE and ARBs trials. IDNT trial, a renal trial. So whatever they said, because whatever endpoint you take, whether you take an endpoint doubling of creatinine, whether you take end-stage kidney failure, whether you take renal death, in all the trials, endpoint is generally end-stage kidney failure, or the need for dialysis, or the need for transplantation. So you have to see how much protection they are offering. ACE and ARBs, 20%. You have got SGLT2, how much that is offering? 40%. So you have checked 20% by ACE, you have checked 40% by that. If you come to MRA, you can check another 20%. So possibly 70-80% progression you can halt if you are giving these drugs, and the newer drugs may be more helpful. So that is what you are trying to check in these patients, that we should check the GFR drop to just around 3 ml or below. That is your target. So that, as a nephrologist, you have to practice. Anything? Or we go ahead.
So just I would like to add on to this point that nephroprotection given in MRAs in Fidelio Figaro studies, that they have not used SGLT2 inhibitors. So that is a very big catch. So now, because that is an established part of the treatment now, so any new study coming with MRAs, and newer MRAs are also coming, so they will have a very difficult time to prove, superiority in this group of patients. So then your patient, coming back to your patient, so he was enrolled for kidney transplant.
Yes, sir.
And he is now admitted for the
He-
same, or he underwent?
He underwent, sir.
Okay, so now let us proceed with that. So you have declared that patient is ESRD.
ESRD.
There is no reversible cause, whatever we might do, and he is started on dialysis.
Yes, sir.
Yeah, or
Actually,
is it a preemptive transplant?
so he opted for preemptive, but within 1 week he developed symptoms like
Symptoms, so he
nausea,
was on
vomiting, so he
dialysis.
has to undergo.
So what is
hemodialysis.
preemptive transplant?
So before the onset of the uremic symptoms, if the patient underwent renal transplant, sir.
At what GFR you can take him?
So 15.
Okay, good.
So preemptive transplant is without dialysis or with 1 or 2 dialysis within 24 hours of transplant.
Transplants.
Okay, so then how did you go about that then? Let us proceed with further history then.
He was being worked up for the renal transplantation, the donor being wife, sir. However, within 1 week, the patient developed nausea, vomiting, decreased appetite, and swelling over bilateral lower limbs. So he was initiated on hemodialysis via femoral hemodialysis catheter, followed by the right IGV hemodialysis catheter insertion. Simultaneously, he was being worked up, and he remembered that after 4 sessions of hemodialysis, he underwent repeat coronary angiography before the surgery. His blood group was B positive, and his wife's blood group was AB positive. So they were consulted regarding the initial preparation with the plasma exchange. He remembered he received one costly injection 15 days prior to the transplant, that is on 5th of July, and he was started on immunosuppressants. He remembered it to be the Pangraph and the Mycept. 4 days after the injection, he was initiated on the plasma exchange. And, he was admitted on 10th, and his first session was done on the 10th of July. Sir. And after that, 4 sessions of plasma exchange were done. His last session of hemodialysis was done on 16th of July, and last session of plasma exchange was done on 16th of July, and he underwent the renal transplant surgery on 17th of July. Sir.
This is 1 week back.
Yes, sir.
Okay.
He remembered he passed about 13 liters of urine on the day of the surgery.
What was the titer?
So actually,
What was the initial titer and what was the titer before transplantation?
so initial titers were 1:32, sir, both IgM and IgG.
And
What is
before
important?
transplant,
Before transplant, it is 1:8, sir.
and sir is asking which one is important, IgM or IgG?
IgG, sir. IgG is more important.
So 1:32 was the
Initial
titer, and you brought it to 1:8.
8.
How many plasma exchanges you gave?
So 4 sessions has to be given, sir.
What type of plasmapheresis was done?
So it was centrifugal plasmapheresis, sir, by the centrifugal machine.
What are the types of plasmapheresis?
So membrane plasma separator and the centrifugal.
Okay, this is depending on the way you separate the plasma. But other, like how you can classify on type of therapy also, whether it is a plasma exchange or it could be double filter plasma exchange,
So
or it could be immunoadsorption.
It
Okay,
is
these are the
plasma
three
exchange, sir.
plasma exchange.
Plasma
you have done.
exchange.
Okay.
Okay. So then, what other significant history you have asked for risk stratification?
So history of blood transfusion.
Huh.
That
How
I
many
wrote
blood
down.
transfusion?
No, he didn't receive any blood transfusion.
And what, did he receive any expensive medicine at time of
She
transplant?
mentioned.
Yes, sir.
She mentioned
15 days
She
also, and
mentioned
on the
15
day of
days before,
surgery.
sir.
15 days before.
Before.
But
And
at the time of
at
transplant,
that time of transplant,
basically induction, did he receive induction?
Yes, sir. And he received 1 dose on the day of before shifting to the OT, and second dose was given on day 4th of the surgery, after the surgery.
How much rituximab you gave?
Sir, in this patient, we have given 500 milligram of rituximab, sir.
What is recommended now?
So
How much
nowadays,
people are practicing?
nowadays, sir, 200 milligram or even 100 milligram has been tried in some studies.
Yeah.
Sir.
Because you find that whatever blockage you want to achieve of CD19 or cells,
Beneficial effects are
the
seen with
beneficial
this.
effect is even with 100 milligram. So there is no point of giving too high doses. And if you give high doses, then possibly you are causing more infections
Infection
in them
risk.
and earlier infections in them. There was a beautiful study which came from Switzerland. So all the Swiss centers, they participated in that. So it was only that ABO compatible versus ABO incompatible transplant. They compared. And if you are using smaller dose, 200 milligram or 100 milligram, the risk of infection is almost comparable. There were some bacterial infections which appeared little earlier. So keep in mind that these days you can get away with smaller doses. Rather, there are centers which are not using rituximab also nowadays. And because this titer 1:32, many centers in Japan, in India also,
Yes, sir.
I mean, even Calcutta,
Calcutta.
they are accepting 1:64. Dr. Tanabe, all of you must have heard him many times. And there are many centers now in Japan who are not even doing titer. They just give 4 plasma exchanges and proceed ahead. But we are not advocating that. We are advocating be scientific. So once you found a titer of 1 in 32 is a small titer. It can be that you required 4 plasma exchanges, but generally, even with 2, you could have possibly, generally, because 1 log fall is generally there with each plasma exchange, from 32 to 16 to 8. And what titer you accept?
Sir, 1:8 in our center. We usually accept 1:8.
Which method you are practicing, that also you should know.
So we are using gel column method to
Which is
determine the titer.
which is better method? No, what you said is right. The tube method and gel card method.
This is the
Gel card method
this
is better. It is little more sensitive. It requires one more dilution. So that is a better method. That's fine. So whatever method you adopted, with that you brought it to 1:8, and then you went for the transplant.
Yes.
And induction, what did you give?
Sir, as he received 2 doses on day 0 and day 4, so likely basiliximab was given to him.
That also, of course, is a very debatable issue that many centers, even Johns Hopkins, etc., they are practicing basiliximab because of the reducing the risk of infection. But possibly many centers in India today are using smaller doses of rituximab, and there is no comparative data. The comparative data, some of the unpublished data is with 3 milligram ATG, but as you said, your center, many centers are using even less than that. We had a meeting of Sanofi once, and all the Indian delegates were there. There are people who are using just 2 milligram.
So
Gangaram is using 2.7 milligram, I believe, 0.9 milligram per kg body weight, 3 sittings. They are using 2.7. So different centers are happy with different centers. So we don't know. With the smaller doses, possibly infections will be less. And some people are using ATG only. Many centers are using rituximab plus ATG, maybe in a smaller dose. Go ahead.
So, now he remembered that he passed 13 liters of urine on the day of surgery, and his serum creatinine decreased to 1.08 on post of day 5. Sir. This is the present course. Sir.
finished?
Yes, sir.
That's all.
So what is your final diagnosis?
So, renal allograft recipient, post of day 5, native kidney disease being diabetic kidney disease, donor wife, ABOi incompatible from AB to A, status post desensitization with nadic serum creatinine of 1.08, with diabetic retinopathy and diabetic neuropathy, hypertension, hypothyroidism, CAD status post PTCA.
Chal, you can tell us something about diabetic retinopathy now.
So,
What really happens, how it happens.
so the basic mechanism behind the diabetic retinopathy is whenever there is increase in the hyperglycemia, the pathways like hexosamine pathway, fructose pathway, and ACE pathways, they got activated, and protein kinase C pathway was also get activated, which lead to the loss of the pericytes in the around the vessels in the retina, following which there occurs changes in the eyes, which can be divided as the non-proliferative or the proliferative changes. So non-proliferative can be mild, moderate, or severe. In the mild non-proliferative diabetic retinopathy, there are microaneurysms, that is just outpouching of
First change. First, keep in mind there is only
hypoxia.
Whatever you do in diabetes, whether it's a glycation, non-enzymatic, or glycosylation, it's a combining of glucose or the products with the collagen fiber. You are basically, as you said, there is a leakage. So that is what first is a fluorescein angiography. If you do, the dye starts leaking out. So that is a hypoxic change. Now the hypoxia is there to the retina. There's less blood. The vessel is narrow, glycosylated walls. So then the microaneurysm develops. To supply more blood, it gets dilated. Then the next stage is the microaneurysms. Then
Since there occurs, then after that there are dot and blot hemorrhages, which means there are hemorrhages in the deep retinal
first there will
layer.
be What more? If
Soft-
there are,
hard exudates can be.
what is soft exudate?
So soft
Which is bad, hard or soft?
So soft exudates are because of the ischemia of the nerve fiber.
So soft exudate is an infarct.
Clogged.
If there is total, let's say, blockade of the vessel, the retina becomes infarcted. So that is a soft exudate. As you rightly put, soft exudate are the worst. They are only suggesting a pre-proliferative stage. And then you said is the hard exudate which leaks or which are vexy exudates. And there are hemorrhages. What is dot blot hemorrhages?
So dot blot hemorrhages are the hemorrhages in the deep retinal layer, whereas the flame-shaped hemorrhages are the hemorrhage in the superficial layers of the retina.
So that is only where the hemorrhage is. So depending on the location, it can be flame-shaped or it can be dot or blot hemorrhages. And proliferative?
Proliferative, there can be the neovascularization or vitreous hemorrhage.
And retinal detachment.
Retinal detachment.
So these will be the changes in that. And you have not told us the pathology. If we have to do the kidney biopsy in any patient with, let's say, with stage 4, what do I find?
So there will be the thickening of the glomerular basement membrane, mesangial expansion, or there may be the Kimmel-Still-Wilson nodules which are pathognomic for diabetic nephropathy, sir. Or there might be, if there is an advanced
What percentage
disease,
of people may have KW lesion?
so 10 to 50% of the patients.
Maybe less, around 20% of the population, not 50%, may have Kimmel-Still-Wilson lesion. Okay, then?
Or sir, there might be the diffuse glomerulosclerosis.
Majority of them will have diffuse
glomerulosclerosis.
Okay. So that is, and what are...
or there may be the interstitial or the vascular changes also, sir.
Are there some capsular drops or something?
Yes, sir. These are the exudative lesions which can be seen. So capsular drops are changes which are seen in the endothelium. And
so they are the pathological changes. Okay.
So coming back to the transplant part, we have a lot of discussion we can do on that, but I'll take few questions only on that. One thing I want to highlight is that rituximab, it has been studied at the dose of 35 milligram up to 1 gram, and even some centers use 40 milligram per meter square to 100 milligram per meter square, which is good enough. So that was one which we were discussing. So we have now shifted to 200. We are planning to do more on 200 only. And ATG we use 1 milligram per kg for 2 doses in these patients. Okay, so where does the rituximab act? How does it act?
so rituximab act on the B cells, which are it is basically anti-CD20 monoclonal antibody. So it act on the B cells only. But it will stop the formation of the newer antibodies. But the antibodies which are already formed, they are not targeted by the rituximab.
Okay.
So we
and
have
it
to
will not take care of memory cells.
Then also.
And it will not take care of plasma cells
also.
Because plasma cells don't have CD20
CD20
antibodies. So when these patients develop rejections, rituximab sometimes doesn't work just giving rituximab, because plasma cell don't have CD20. So, and then what are the methods of desensitization? Like initially how desensitization was done? Do you know when this was started, in which year it was started? ABOi incompatible transplant, and when in India cases were there?
Sir, in India, first case was done in 2011.
Sometime that was
earlier. It was done in 2008 or 9 in CMC Vellore. CMC Vellore, I recollect, there was a child who was a patient,
and his father was a donor.
Mother was a donor with incompatible blood group. They insisted that we want only, there's no other donor. So there's a beautiful story given by Dr. G.T. John. So he mentions how we proceeded ahead, how we did plasmapheresis, how we removed antibodies. So that was 2009, if I'm not mistaken. That was the first in India. I recollect in 2011 or 12 when there was a conference in Ahmedabad. Indian Society of Nephrology, I was conducting a symposium on ABO incompatible transplant. I think 2012 or 13. And that is the time I collected the data from all the centers in India. So highest number was that time done by Jaslok, Dr. Gandhi. Gangaram had done 4 that time. Apollo had done 4. So total we could get, there were around 60 or 64 transplants done that time.
At PSRI, we did first in 2014.
Okay. So Army, we did somewhere earlier. We did almost maybe same time. So it gradually picked up. Japan, of course, if you look at the pioneers are Japanese. They started in 1980
80.
and they carried on only with splenectomy
Yes, sir. Initially splenectomy was.
because this rituximab was not approved for use in Japan till 2005. 2005 only they shifted to rituximab.
Rituximab.
And once they published the data, somewhere in 1998 or 2000, that is the time then John Hopkins or other centers, Mayo College, they started picking up on that. Because you look at 30% of the transplants are unrelated, are not, I don't say unrelated, are either
Incompatibility.
HLA incompatibility is there or there is a ABO incompatibility. So that's a big number. So what is the general outcome from your point of view or anybody who wants to say vis-a-vis ABO incompatible transplant vis-a-vis ABO compatible transplant?
So
What is the outcome?
So it is the initial 2 to 3 months in which there is increased risk of infection or rejection in the ABO incompatible transplant. But once that has passed, then the graft survival is almost comparable in both ABO compatible and incompatible transplant at 1 year.
Look at the risk. There's a beautiful article, I had read it long back, I think it came 2-3 years back in Jason. That is a beautiful article and they did mention that if the survival, 1 year survival is 96, 97%, so it was 1 or 2% inferior, but the rejections are much higher. Rejections, it is somehow, we don't know whether plasma exchange does some good or not. Like in your case, people would have gone for 1 in 32 also. You have got 1 in 32, let's say it was 1 in 16, or let's say it was 1 in 8. Will you do a plasma exchange or not? Many centers believe that they don't know what it removes. They always feel comfortable if 1 or 2 plasma exchanges are given.
Sir, we are following that now. After one learning lesson,
Yeah.
we did a transplant with 1:4. We had ABMR.
Yeah, because
Without plasma.
Without plasma. We don't know why.
So
it is
we have-
same thing happened
what
in
I follow
Apollo
is
also.
2 sessions of plasma to all patients, whatever be the titer.
So that is what happened in Apollo also. 2 cases, 1 in 4 titers. On the table there is a so-called hyperacute rejection. So we don't know whether plasma exchange gives something to the person, whether it blocks something. But many people are comfortable by giving 1 or 2 plasma exchanges. And Japan does not believe in immunoadsorption. Keep in mind, even in USA, there is no immunoadsorption. They are only doing plasma exchange. Europe is doing immunoadsorption.
Actually, the products used were initially developed in Europe, so they are available there. Other countries got them later. Just now, US is just starting out with that. So that is why probably more data on immunoadsorption. But if you go to any guidelines or any newer articles, immunoadsorption would be a method of choice if you want to remove. Because what are the advantages of immunoabsorption over plasmapheresis? Can you
So
tell?
there is no need for the replacement fluid, like in plasma exchange we have to give the replacement fluid. So, and there is only the isolated removal of the immunoglobulin, so there is no loss of the albumin occurs or no coagulopathy occurs, which is there with the plasma exchange.
What happens with plasma exchange?
So in plasma exchange,
If you are taking, let's say, 3 liters or 3.5 liter one exchange, how much antibodies you remove And what all you remove?
So along with the globulins, some albumin is also removed, sir.
That
And
is
the
one.
coagulating factors
What-
are removed, sir.
Yeah, that is what. How much coagulation factors are removed? So it is
So
almost
it is not with the only
65%.
one plasma. It is
65% of the
60%.
coagulation factors get removed. Likewise, almost 60, if you are doing 1 to 1.5 plasma exchanges. So that 65% of proteins or 65% of antibodies are removed. So that is how, what happens in rebound then? Because whatever antibodies are in the extravascular compartment, they will come inside. So next day you might get a higher this thing. Isn't it? So that is why there can be oozing at the time of actually transplant. So many people advocate that you should not give plasma exchange on the last day. Wait for a day so that let some coagulation factors form.
So
Or if you want to give FFP or
Yes, sir.
something.
So we were discussing advantages of immunoadsorption. So what other advantages is that you can treat more plasma volumes, right? In normal plasmapheresis, you will do one plasma volume. In double filter plasmapheresis, we generally can do 1.5 to 2 plasma volumes because replacement fluid is very less. You
Yes,
require
sir.
only 500 ml of albumin with 1.5 plasma volume with DFPP. But in this, you require equal amount. Like if you are doing 3 liters plasmapheresis, then you require 3 liters of 5% albumin, almost equal amount. And you might want to give FFP also because of loss of more coagulation factor. So in immunoadsorption, you don't have these problems. You can even do 7 to 8 plasma volume in continuous session for 12 hours. And this filter is not saturable. You can remove even with one long session. So that is the advantages with that. But disadvantage,
Cost issues.
cost is the main disadvantage. So and do you know when this blood group antigens were discovered? Which year? Just idea?
1950.
Huh? Anybody?
काफी पहले जाना
काफी
पड़ेगा।
पहले का।
काफी पहले जाना पड़ेगा।
So Landsteiner, in
Yeah,
which year?
Landsteiner.
1905.
Yeah.
Long back. So when transplants were started, ABOi compatible was also done in 56, 57, and they lost all the kidneys because of that. 10 ABOi compatible case series is there in literature. 8 were lost. Only 2 were working. Luckily, because of that A2 type of this thing, because the titer is less and reactivity is less in that. So there's another new information which I was reading yesterday, so I could find is that, do you know when these antibodies appear in your blood? Anti-A or anti-B antibodies?
Sir, at the in the beginning
At
of the
birth? No.
no, sir. After the
You're not
birth,
born
in
with
the
the
initial
antibodies.
life, in the initial life of the years, when the body comes in contact with the gut microbiome. Or
Yes, so it is the gut microbes which will occur at 4 to 5 months of age,
Yes, sir.
and when the child starts eating, and that time you get these
Antibodies.
antibodies because of antigen similarity between the gut, the bacteria and these antigens. So corollary to that is that the probiotics which you use, they can induce antibody formation. And now we are using a lot of probiotics in our renal patients. So that is one area which I think we should see. We are using so much of that they can push the titer of antibodies. So that I thought was an interesting read.
Yeah.
So we should see that part. We are not seeing that part. I think that's any other things.
He has answered you. He has told you. How do you replace fluid in that plasma exchange?
Either with the 5% of the albumin, or we will replace it with the fresh frozen plasma, sir.
Which plasma group you will use?
So either the AB blood group or it is the donor blood group.
Yeah.
Okay.
Yeah. Any questions from you? What are you testing in diabetes? UACR or UPCR?
So In routine, we are testing UPCR only, sir, but it is recommended in diabetics patients to test for UACR as it has direct correlation with the cardiovascular mortality, sir.
So you should test, and at that too, if there is a small amount of albumin, you have to test. If you are testing UPCR, you may not get that. So UACR is the recommended methodology. And what time of the day you want to test? Preferably first
Preferably in the
morning
morning,
specimen.
but
If possible, that first morning specimen. All right.
There are some books, sir, which will be mentioning second morning sample, but you have to see first morning is preferred. Then second, have you read AJKD last month? There is an original study on UACR, and they have done UACR in, I think, more than maybe 1,000 patients or 600 patients, and they have seen the variability, the variability in the same patient. The variability is up to 10 times. You will be amazed to see, sir, in that.
Yeah.
It is the original data, prospective, or I don't know if it is prospective, but in the same patient, the variability is 10 times. If you compare to gold standard, there is 24-hour collection. That is the best method. But you just doing a the albumin creatinine ratio, the variability is too much. So what you can do is, one thing is that early morning sample mein, the variability in the exercise will not be there, diet will not be there. Second, blood pressure control should be same, then the variability will be less. So this variable, and the time of the day should be same, because there is a diurnal variation. Okay, so it is a very tricky test. So many studies are based on that, but you just go through that article. Everybody, I will say everybody to see that, and it highlights the
The
discrepancy
fallacies
and
and
fallacies of this test. Okay.
Because these were the stress tests what we used to do. A diabetic is asking, let's say, ki, am I going to develop diabetic nephropathy, proteinuria or not? And if he is doing exercise, you can precipitate proteinuria. So logically you say yes. Likewise, if a person is given high protein diet for 2 or 3 days, you can precipitate proteinuria in them. Yeah. So exercise does cause a change. That is what Dr. Bansal highlighted. That be careful, measure it by one particular time of a day. Any other thing you want to?
Any questions in your mind? You have done a case, you have seen the patient. Did anything strike you that you want to ask something like you could not understand? Nothing? Okay. Okay, sir.
Now, diabetes is a common subject, I think. And how do you test albumin in the urine? Or how do you test proteins in the urine?
so in this urine protein to creatinine ratio test, so we go
No,
for
how
the
do you test protein in the urine?
What are the testing methods?
So semi-quantitative methods and the quantitative
Name
methods.
them.
The
What are the
semi-quantitative methods, first of all, we take the urine in the test tube. Up to 2/3 of the test tube should be filled, and we heat it the upper 2/3 portion of the test tube. If there is a coagulum formed, then we add a few drops of nitric acid. If that coagulum dissolves,
Why you add acetic acid or what acid?
so to if these coagulum is because of the nuclear material or phosphates, then it get dissolved with these.
So if it is due to phosphate, it will dissolve.
it will
So
dissolve.
this is
So
called
that
heat
is-
coagulation
Heat
test.
coagulation test.
So that is one. Next,
Then is then there are the quantitative analysis by the immunoturbidimetric methods or calorimetric methods.
what do you do with the dipstick?
So in that the tetrabromophenol component is there. So with that we check the albumin in the dipstick by the dipstick method.
Okay. And how do you do salicylic acid method?
So
You have to take equal amount of urine and equal amount of salicylic acid and then mix them,
and we
and
have
then
to
you find the
read
coagulum
the coagulum
reaction. Okay. Shall we stop? If there is no other question, if there is any question, any doubt, What percentage of diabetics are developing diabetic nephropathy?
So 30 to 40% of the patients are
That's
developing.
a huge number. That's a huge number. I think it has also changed in when we were studying, it used to be 10-15%. Now the figure has become 30 to 40%.
Sir, older books, I would say older like 2000, near 2000,
Yeah.
all data was 40%. Before that, it was even less.
Less.
And now newer data say 30 to 50%. So it is increasing. But one thing is interesting that if somebody doesn't develop nephropathy after 10 years, he won't probably then. And the
Unlikely
age,
then.
and age, if he is more than 60, he has not yet developed. So he may not develop nephropathy.
Because that is what we were seeing in your case. Though the age was less, he started developing at 33.
So 33.
And for 10 years, you said there was nothing. So that was very interesting. If the age was 50, then possibly he wouldn't have developed.
Maybe he missed earlier testing and the type of testing which was done. We don't know. He was checked for microalbuminuria. Maybe he was tested for just proteinuria. So
And
we
he
could
was
miss
not
the
following any particular single physician.
and
He was
foaming
changing.
of urine. There is an article on that only 34% of patients who report frothing of urine is actually proteinuria. So it is published article. So you can say that is the data. And frothing is because of increased surface tension of the liquid, whether it is urine or there is a soap in the commode or whatever.
There's a bile salt in that.
So it's just surface tension is more and it can form this thing. But because of social media and all this information, patients are coming and volunteering beautifully that I've got frothing, please check for my protein. So that is how it has come now. So
Well, thank you very much.